Going to look at the sepsis, where people get confused with the hospital-acquired pneumonia. Usually, sepsis that develops in hospital, there is a focus of infection somewhere, whether that is a UTI, which is a common problem, okay, or that is a cellulitis. There's a focus of infection somewhere. Patient has been admitted for a different reason and now has developed a sepsis. So let's look at the one that causes confusion. The patient was admitted 3 days ago, not 3 weeks ago. 3 days ago, admitted with the UTI. Okay. The nurses are concerned about the patient because the patient is not well. Now, if you look at the duration in here, there is nothing like patient has been treated and now is okay. It's 3 days ago, admitted with a UTI. The nurses today are worried about the patient. So which means he has got worse. Nurses are worried about the patient because the patient is not feeling well. Now, when you examine the patient is having some abdominal pain. There is loin pain. What that suggests is he still has got a UTI. Okay. He has suprapubic pain or loin pain. When you examine, he has got crackles on the chest. There is infection and temperature is high. What can we say about these two problems? It's a urine sepsis that has spread to the chest. Okay, a urine sepsis that has spread to the chest. You can see it's only 3 days ago admitted. There was no cure of the initial problem. Another one develops. So it's not a simple hospital-acquired pneumonia. No, it is a spread of infection, which the initial focus of infection was in the urine and now has spread. So that's what we're going to be looking at. In terms of the blood pressure, will be low. In terms of oxygen, it will be the same. So in terms of the vitals, what you find when to assess the same, there is crackles. But if you don't miss abdominal pain, suprapubic or loin, you can see there's still signs of UTI and there is a chest infection. So it was a urine sepsis as the focus of infection that has spread. It's a different from a hospital-acquired pneumonia, admitted a week ago, 2 weeks, 3 weeks ago, treated successfully, and there is a new problem. And upon examination, there is nothing suggesting an ongoing urinary infection. So how do we approach that task? It's very similar, but our diagnosis is different. So Harlow, Mrs. Brown, confused because it's an elder again with infection. Random things, okay, maybe random things in the station, maybe coughing again. So address those ones, but the patient is responding. Since the patient is talking, the airway is patent. Then you go to B, the breathing, okay? Oxygen is low, as usual, give oxygen, yeah? You attempt to take a history, you have to attempt it, yeah? Are you having any chest pain? Are you having, palpitations? What's bothering you? You're speaking random stuff. So the patient is confused. I will check the general notes of the patient. If you didn't read it properly to understand the task, it's time to look. When was this patient admitted? What treatment has been done so far? And what else has been done? Okay, look at the drug chart as well around. Your notes, remember, is your task. Then you perform respiratory examination. What do you find? There is crackles on the chest. The monitor, we looked already, shows the temperature 38 degrees. So not much difference the hospital-acquired pneumonia, but it is a history on how the information, how the chest infection developed that will tell you the most likely diagnosis. You need a chest x-ray, you need an ABG. The blood pressure is low, heart rate is high, monitor sinus tachycardia, okay? Full ECG, as usual, same stuff. Do we need an abdominal now? We don't need an abdominal now. So we're gonna do this later because it's not bleeding, it's not postoperative. Manage the circulation, get an IV line done, send the routine bloods. Do we need IV fluids? Again, I would do the fluid challenge, 500 ml over 15 minutes, okay? Then you would come to disability. The patient is confused, but an AVP system is alert. PP's glucose, normal. Let's review the treatment. We have given oxygen. You're going to find oxygen is going to go above 94, which is good, but sometimes does not go in chest infection. You just have to be aware. Because there is chest infection, patient will be desaturating. So oxygen would generally improve from 88%, go to 92%, but never above 92. Sometimes people try to keep on, okay, I'm going to give 100%, I'm going to give again, I'm going to give again. It's not an asthma, it's not an anaphylaxis. We're going to get oxygen back to normal. This is never going to be to normal. There is a chest infection, they will continue desaturating. both whether it's a hospital-acquired pneumonia or it is a sepsis, the saturations will be somewhere around 92, continuing desaturating. Okay. IV fluids, you're given IV fluids. If it has improved, it is good. If not, then you give IV fluids, you repeat the fluids again. Then you go to E. Now we're going to do the abdominal examination and external genitalia, look at the legs and palpate. Okay, so the blood pressure goes back above 90 systolic, may become 100, may become 110. Okay, the oxygen 92%. We're never going to get it back to normal because it's an infection. Okay, then you're going to discuss management with who? With an examiner. The examiner asks you the question, how will you manage this patient? Now, this is sepsis. Okay, there was abdominal pain on examination. There's loin tenderness, there's suprapubic tenderness because there's a UTI. Temperature was higher. Okay, so you still have to tell the examiner your assessment. So I've assessed him since XYZ. Okay, who is confused? Okay, and upon assessment, the oxygen was low. Okay, the blood pressure was low. He's tachycardic. Abdominal examination, there is loin tenderness, suprapubic tenderness. Okay, he has crackles on the chest. I'm suspecting the patient has got urine sepsis that has spread to the chest. So what I'm going to have to do, I've sent the routine investigations. Yeah, I'm going to send the investigations. So routine blood testing, and then special blood tests such as blood culture, lactate, ABG. Okay, then we're going to do a chest X-ray. We're going to do the urine culture as well. Okay, and then we're going to give the patient oxygen. Going to give IV fluids. Going to give IV antibiotics. Okay, for sepsis. And you're also going to discuss with the seniors. If they suggest anything different, you would of course apply that management. So because the patient is confused, you're going to discuss management with an examiner. Now here we approach it as what? As a sepsis. And yes, everywhere where the temperature is higher, we can give paracetamol to reduce the temperature. Okay, good. So we do a sepsis protocol in here. We do investigations, routine blood testing, and then special blood testing, such as blood culture, lactate, ABG, and other tests like chest X-ray, urine culture. We also need them. Then you're going to give the patient oxygen. If oxygen is low, we're going to give IV fluids, and we're going to give IV antibiotics. Okay, so this is a sepsis, and don't confuse between a sepsis and hospital-acquired pneumonia. There is a clear connection of a UTI to the chest infection, how it is spread. The other hospital-acquired pneumonia, the patient was treated well, and he had recovered from a UTI.